it feels to me that this whole arena of measuring what matters and understanding what matters and attending to what matters for people who live with any health condition is a really complex arena. And we can come into it through trying to understand the philosophies, the concepts, the contexts, or the purposes, or indeed the activities. So what I thought I'd do is I would take my own personal frontline work as a kind of a starting place. And my starting place, I've been working with people with long-term pain as a consultant for about 25 years now, is that when I started, and indeed for about the first 10 to 15 years of my practice, I was using kind of national measures, and they made no sense to me. And they made no sense to the patients, the people with pain that I was working with. So either I was deluded, or I wasn't any good, or they were the wrong measures, was the way I was starting to think about it. And the way I was working was giving people spider plots. So on the right of this diagram here is a spider plot, which around the edge are a variety of different aspects of the way people live their lives that they might want to talk about and work on. Some of those aspects might be housing, or relationship with my children, or the way I relate to myself. You know, hey, I hate myself sometimes. Or it might be my condition. So in providing a personalised service for people with long-term pain, we might be attending to one, two, or all of those rather complex issues, and we just were not capturing them in the data, the measures that we were using in the clinic. And I started to think, actually, we're using standardized data sets here that have been mandated from a group of researchers or a group of policy people that bear no relationship to the individual person that I'm working with. So these national standardized data sets that are being used, the purpose for which they're being used is very often evaluation or policy making or changing the way that we fund services, are not applicable at the front line. They're just not working. They have no meaning. And I think that's an ongoing problem. What is the purpose for measurement? Is it to allocate resources, or is it to support people at the front line? Are they valid, relevant, and meaningful at the front line, or are they only valid, relevant, and meaningful for researchers, for commissioners, or in Whitehall? So what actually does matter to people, which really ought to be the purpose of the services that we offer? It is finding out and attending to what matters to individuals, isn't it? What matters to Dorothy, who might live with 3 long-term conditions, who might have quite high levels of anxiety, quite low levels of confidence, who might be having difficulties in her marriage, who might not have enough money, and who might have a dodgy knee that's getting worse and worse? What matters to her? Well, what matters to Dorothy is going to be influenced by her relationships with her health. And actually, from an intrapsychic perspective, actually coming into relationship with your condition or your conditions is of paramount importance. So the relationship between Dorothy and the way she sees her health is really important. Her relationships with the world are incredibly important. And then she'll have this intermittent relationship with the system. And that's the only time that we tend to measure what the system can do. So what matters is her relationships with herself, her world, and the system. And it's hugely dependent on the context. And it feels to me that there are a number of contexts where Dorothy engages with the system. There's going to be episodes of care which are unheralded, which could be life-threatening, an acute myocardial infarction. Now, at that time, what matters to Dorothy is, please save my life. Treat me with dignity and respect, but provide me with an efficient, effective, safe service. She might have other unheralded times when she kind of just comes in because her knees got really bad. She might have anticipated episodes of care where, let's say Dorothy develops an esophageal cancer and knows that she's reaching the terminal phase, and as she reaches the terminal phase, she knows that she might suffer a life-threatening event, in which case it would be really good if she undertook advanced care planning so she is in control of what happens to her. She might have other non-life-threatening anticipated events if her COPD gets worse over the winter. So those, to me, are the 5 key contexts within which we need to understand what matters to Dorothy and within which we need to design specific measurement systems. When Dorothy then does interact with a system, there are often implicit rules of engagement. There's quality. If she has an acute myocardial infarction, what's going to matter to her is safety and effectiveness. If she's interacting with the system in a proactive way and is figuring out how to manage her 3 or 4 long-term conditions, she's going to value a safe and effective service, but she's really going to value a service that takes account of what really matters to her in her everyday life. Those rules of engagement are also going to be bounded by the ethical principles that healthcare is informed by. Beneficence, doing good. Doing good, if you have an acute myocardial infarction, means doing a really good clinical job. I would say that doing good when working with people with long-term conditions is promoting autonomy. It's promoting autonomy. So moving from the idea of a person as a passive recipient towards the idea of the person as an active participant. Moving indeed from a biomedical system, which is deficit-based, towards a system of working with people which is based on their strengths, their abilities, their capabilities, and the community assets which surround them. So these are really, really, really different ways of working with different values, different concepts, different ideas, and indeed, they will need different measurement systems. In an unheralded, life-threatening event, what matters to Dorothy is going to be safe and effective treatment delivered with compassion and affording her dignity and respect. I would say to you that what matters to Dorothy in every other instance is living a valued life, being listened to by the system, being supported to make wise decisions and to take actions in the context of the life that Dorothy wants to live. We currently don't measure that. We currently don't measure that. There are some research studies looking into what matters to Dorothy in the context of her everyday life and how the system can support her to live a valued life. But they are in the very early days. So if we're going to build a coherent measurement system, context is paramount. We need it to be coherent, integrated. We need all the measures in one place, and for there to be as few measures as possible. There is no magic bullet. I believe that we should always start with what matters to Dorothy, and we currently start with what the system believes Dorothy wants or should have. If we start with measures that matter to Dorothy, we can then co-produce a measurement system alongside what is possible in the context of the rules of engagement with the current system. And I believe we should build a measurement system upwards and not downwards.